right. Good evening, everyone. Thank you so much for taking time out to attend this week's session. Tonight, we're going to talk about are antibiotics an effective way to prevent infection following tooth removal? So, just a background, the most frequent indications for tooth extractions are dental caries and periodontal infections. When tooth extraction is conducted, a wound is in the mouth and that can become infected. Usually, systematic antibiotics can be prescribed to patients to prevent any complications due to infection. However, taking antibiotics unnecessarily fuels antibiotic resistance. Some patients can be allergic to antibiotics and have drug interactions or have unwanted effects such as diarrhea and nausea. So Cochrane did a systematic review of all studies. They want to determine the effect of systematic antibiotic prophylaxis on the prevention of infectious complications following tooth extractions, and also to understand whether antibiotics work differently in healthy patients versus immunocompromised. So again, a systematic review was conducted. They searched for studies that assessed the effectiveness of antibiotics compared to placebo, given when no infection was present in order to prevent infection following tooth extraction. They also assessed, of course, the quality and reliability of the evidence of individual studies and the body of evidence. So what they found were 23 studies with a total of more than 3,200 participants. All the studies except one were all healthy patients in their 20s. 21 of the 23 studies assessed the removal of wisdom teeth in hospital department, dental departments, and one assessed the removal of other teeth, and one assessed complex oral surgery. None of the included studies assessed tooth extraction in general dental practice for the removal of decayed teeth. So what they found was that 16 trials assessed as high risk bias, 3 at low risk, and 4 as unclear. But the basis was that compared to placebo, antibiotics may reduce the risk of post-surgical infectious complications in patients undergoing wisdom teeth extractions by 66%, and also can reduce the risk of dry socket by about 34%. They found that antibiotics may cause more brief and minor unwanted effects for these patients. There was no evidence that antibiotics prevent pain, fever, swelling, or problems with restricted mouth opening in patients who had wisdom teeth extractions. There was also no clear evidence that the timing of the antibiotic given, so either given pre-op, post-op, or both, was important. It also did not, the study also found that there were no studies to judge the effects of preventative antibiotics for extractions of severely decayed teeth and teeth in diseased gums, which previously mentioned is the cause or the frequent cause of why we do extractions in the first place. And no extractions in patients who are sick or have low immunity to infection. So in conclusion, results of this review may not be generalizable to all people undergoing tooth extractions because vast majority, 21 of 23 trials included healthy patients undergoing impacted wisdom teeth extractions performed by oral surgeons. None of the studies also evaluated tooth extractions in immunocompromised patients, and none of the studies in young children or older patients. They were healthy and mainly in their 20s. There was also low certainty evidence that prophylactic antibiotics may reduce the risk of infection and dry socket following third molar extractions when compared to placebo, and very low certainty evidence of no increase in the risk of adverse effects. Therefore, clinicians should evaluate if and when to prescribe antibiotics before dental extraction for each patient on the basis of the patient's clinical condition. So if they're healthy or affected by a systematic pathology and level of risk from infective complications. Immunocompromised patients also need an individualized approach in consultation with their treating medical specialists. Of course, we have the knowledge of all the conditions that patients may have, but their medical specialists are more for the stability of their conditions. So in wrapping everything up, when deciding whether to use antibiotic prophylaxis to prevent infective complications following tooth extractions in healthy patients, the practitioner should consider the possible increased risk of mild adverse effects, which is at least 1 for every 30 patients treated, the low rate of infectious complications, about 40 patients treated to prevent 1 case of dry socket, the lack of serious complications even in the absence of antibiotic prophylaxis, and of course, antibiotic resistance. And that's the end of my presentations. Thank you for your time. And if anyone has any questions, feel free to ask away.
Amin, thank you very much for this presentation. Now I'm gonna start to tell you, like when you looked at the study, they looked into administering local anesthetic. One of the primary, what was the primary study objective? And what was the secondary outcomes? What they were trying to see?
They want to see the effective systematic antibiotic prophylaxis on the prevention of any infections following tooth extractions.
Perfect. What about the secondary outcome? There is about 6 of the secondary outcomes, right?
They want to know the differences between healthy patients versus the immunocompromised.
And about the swelling, the dry socket, and
yes.
specifically, and there's about 6 of them, right? If you looked about the 89 pages, not the summary, you know, like on page 3 or 4 in the study, they mention the primary outcome and the secondary outcome. And you look at the secondary outcome, there is about 6 or 7 of them. So those 6 or 7 of them, have you noticed that they've actually started to look into 6th day, on the 6th day, and on the 5th day? Have you actually noticed that?
Yes, there's a whole table. I was talking to Fatma. I can't seem to open it anymore. The article.
Right. Do you have
pain, fever, opening of mouth?
Absolutely. So those are the common things that we know for the extractions. Excellent. Now, do you have an idea, or can you tell me, or can you tell everybody, is that why do you think they've looked into the situation after 5 days, not immediately?
I'm not sure. Why did they look at the complications? Those 6
Yes. Why would they look at swelling? Why would they look at pain on day 6 and day 5? Why did they specifically said day 5 and day 6?
Usually within around 3 days is when swelling, pain, complications are reduced. Day 5 is when, if it persists, then an infection can be present.
Absolutely. So because to kind of rule out the natural phenomena of, inflammation in the beginning, you're absolutely correct. That is the reason for this. Now, you've looked into it very good, and you've got 66% reduction of an infection, right? Isn't that a high percentage, you think?
There is, but in the studies, there were lots of biases as well with it. And also it just did healthy patients and wisdom teeth extractions.
Right. So we're basically looking into the prevention of infection following wisdom teeth extraction. And they found that there is a reduction of infection of about 66% of the cases, correct?
Yes.
All right. Do you really think this is a high percentage?
I do not, because the trials, they had high risk biases.
Okay, but I think the only issue over here, I still think it's a high percentage, but the only thing is advantages, disadvantages when it comes to one thing. Because if you have got a healthy patient and 66% of them have prevented upper infection, and you have some adverse event associated as well, right? So you might eliminate the infection, but you might cause an adverse event, correct?
Yes.
So what is the chances of developing an adverse event? What does the study tells you? It's like what? Is it 1 in 30%? Is 1 in 30, sorry?
1 in 30.
Yes. So 1 in 30 will probably develop a mild. And look at it, the word mild. You see, I love this article only for one thing only. It just keeps the door open for us to use our mind. You've said it yourself. The study was done mainly by oral surgeons. It was done mainly in dental offices. It was mainly done in healthy adults and a young age, back in the 20s, right? But we all know that this is not what we do. Do we agree? Not all of our patients are healthy. Some of them are medically compromised, correct?
Correct.
Now, this study can definitely back you up whenever you try to use your clinical judgment, whether you want to prescribe antibiotics or you don't want to prescribe antibiotics. Do I really feel that there is a need for antibiotics? Sometimes, yes. Would I prescribe antibiotics on an upper wisdom tooth, for example?
No.
Okay, why not?
It depends. Depends on the patient's medical condition. Depends on how his oral hygiene is. Um, the risk of the
Would you give, imagine it's bad, 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 bad. Would you still give it into upper wisdom teeth?
Yes.
You? I probably wouldn't personally. But again, there is no right or wrong answer. This is a valid discussion, right? But if I'm gonna put yourself into my shoes, what do you think I wouldn't give in the upper teeth? Why do you think I wouldn't give?
Because it's on gravity. It's on top. More plaque accumulation on the bottom than on the top.
How about blood supply? Do you really think the maxilla has more blood supply than the mandible?
No.
Yes. Right? So the maxilla gets more blood supply than the mandible. So the mandible has less blood supply than the maxilla, correct?
Yes.
So if you think about the mandible, the major source of blood supply intrabony is the inferior alveolar artery, right? And as we age, that inferior alveolar artery gets thinner and thinner, correct? And if that is the case, then the mandible is going to shift, and the actual blood supply to the mandible is going to come from the periosteum, correct? And what do we do when we do extraction in the bottom teeth, wisdom teeth? We strip the periosteum, right? So we cut it, we open it, we retract it, and we probably sometime stay for a long period of time trying to cut the tooth and take it out. And in the due process, we might damage the periosteum, correct?
Yes.
So we're depriving the mandible off from blood supply. So if we have less blood supply to the mandible, do you really think that we're going to get higher chance of infection or less chance of infection?
Higher chance of
Higher chance of infection. While in the maxilla, there is multiple arteries there. The bone is very porous. On the top of that, you have the periosteum. So the blood supply of the maxilla always dictate that. The other thing is a geographical location, as you said it yourself. Okay, location. If you really think about it in the mandible, right? If you have a lower 8, what, how thin is the lingual plate of bone? I know you do a lot of wisdom teeth right now. Have you started to notice that? How thin is the lingual plate of bone in the 3/8 and the 4/8?
a millimeters, 1 to
Right,
3 millimeters.
less. It's very thin, right? And sometimes it's non-evident. Sometimes it doesn't exist, right? So in the 3/8, if the infection passes through, or if you are aggressive and you break up the actual actual lingual plate of bone, if there was any infection, it will seep through. There will be no barrier, right? If you are up front a little bit, if you're a little bit more forward in the body, if you're talking about 3.5 and 3.6, is there some anatomy that might prevent the infection from moving? Yeah, there is. The mylohyoid muscle, right? So if you have the mylohyoid muscle, that will prevent up the infection from going. So that's the physical barrier, correct?
Yes.
So if you really think about it from this perspective. Now, if you are at the 3.8 and the distal of the 3.7, where the lingual plate is very open and there is no mylohyoid, the potential space infections is extremely dangerous, right?
Yes.
You have your submandibular, sublingual, submental. It can goes above and below the mylohyoid, and it can spread in multiple layers, and it can cause multiple things, and it can cause serious infections, right? Dangerous space infection, right? Do you remember the dangerous space infection?
Ludwig's angina.
No, not Ludwig angina. Dangerous space is more around the carotid arch, the carotid sheath, right? Where the carotid sheath is, and your carotid, and your jugular, and your vagus, correct? And it can go down a little bit further, but you've got your Ludwig angina. You're absolutely correct. Now, that's another thing. Another third thing that you really think about it, in the mandible, as we know, as we age, and this is not written in stone, but if I get you to get a sample of your patients who are 17, 18, 19, and you try to compare, and we ask them, since that we have Dr. D right now listening to this, do you think the relationship between the maxilla and the mandible, are they retrognathic or prognathic, or are they just normal? Are they class 1 skeletal, class 2 skeletal, or class 3 skeletal? What do you feel? I feel that there is more prevalence towards class 2 skeletal, right? So their mandible is usually smaller than the maxilla, correct? Have you noticed this observation? Am I the only one that is noticing this? Maybe. Hello? Hello? Am I still there?
Hello?
Yes,
Yeah.
am I still there? Okay, so the mandible is usually smaller than the maxilla. So if the mandible is smaller than the maxilla, usually the 3.8 tend to be a little bit more impacted, and the 4.8, the 3.8 and the 4 tend to be more impacted. If you're impacted on the bottom, right? If you're partially impacted, this is something, but if you're partially impacted, then you have a pocket. And this pocket can have a whole pouch of bacteria over there, correct? So here is where I am. I'm confronted with a situation. I have a potential risk of infection, right? That will be prevented on 66 of the patients that are healthy. What would it be if my patient is diabetic? What would happen if my patient is immunocompromised? What happens if my patient is taking steroids? What happens if? Where am I going to stop? So I totally agree with the outcome of the study. It's a clinical judgment. The beauty of this article, it just gives you some tools to put in your pockets, is that when you try to make a decision, not to be afraid. There is no right and there is no wrong. There is no white and there is no black. It's always your clinical judgment that has to improve based on multiple factors. Would you be able to decide whether this patient be given antibiotic, or you're just going to become a parrot that says no need for antibiotics? No, there is a need for antibiotics sometimes, based on the location, based on multiple factors. Those factors that the study has looked into and acknowledged: age, medical condition, location, who is the operator. If the operator is somebody who is experienced, or somebody who's doing his first, somebody who took 5 minutes to take that wisdom tooth out, or somebody who's taken him an hour, raising a flap, retracting it, burning the bone, not irrigating, the water coming up from the handpiece, or the water doesn't come out of the handpiece, the suction that the assistant did not clean, multiple factors that we all really know, and we cannot deny it. We cannot bury our heads in the sand and pretend that it's not happening on a daily basis. So the way that I want to come everybody with is that if there is a situation like that, do not just be a parrot. Do not say, oh, there is no evidence that you should. Why are you giving antibiotics? You can give antibiotic providing that you've assessed the situation. You know for a fact that 1 in 30 cases of the time, your patients will have an minor adverse event, minus adverse events. And 66% of the time, 66% of the time, you are reducing the actual infection. So why shouldn't actually be doing this? So I would personally assess every case individually, and based on that, I can make my own decision. Dr. Sally, do you have any ideas that you want to add?
You covered it beautifully. And the article actually covered it beautifully. It's all about clinical judgment. And like you said, there is no right or wrong answer. Some cases call for antibiotics and others, it would be like not as necessary.
Okay, I have a question for Dr. Amin. Dr. Amin, what is the best type of antibiotic that you're going to give your patient? If you decided that your patient needs antibiotic, what type of antibiotic would you give your patient?
Usually give moderate spectrum amoxicillin if they're not allergic to penicillin. Hello?
Hi, I think the rule of the thumb is to have the narrowest spectrum, right? Originally, if you can, but technically, can you? Does that mean that you have to do a culture on your cases? Are you going to be doing that in all your patients?
No.
Right. So what should you do? What do you think you should do?
In terms of?
In terms of that, if you have a narrow spectrum, if you cannot obtain a narrow spectrum on your patients, then what would you do? if you don't know what is the culture that you're trying to do, so what do you think you would do?
Give them a broad spectrum.
And exactly, unfortunately, you have to give them a broad spectrum. What's the downside to this?
That it kills more, the other bacteria that you don't necessarily need to.
Yeah, exactly, and some resistance as well in the due process. Correct? Do you agree?
Yes.
Right. Okay. So this is the downside. So but you're right. That the unfortunately, it's not realistic for each one of them that you're going to be seeing. You're going to swap them, right? So you probably want to give that. Okay. Now, how many days of antibiotic would you give?
Depends, but usually 5 to 7 days, depending on how severe the infection is and when it started.
Okay, well, there is some evidence on this, by the way. They say there is no difference if you have eliminated the source and you have diluted the area with irrigation, you have corrected the area. There is no difference between 5 and 7 days, by the way, of antibiotics. Okay, there's really no evidence. Both of them are actually good. Okay, now, what's some of the adverse events that could happen to you when you give antibiotics?
Allergic reaction, nausea, vomiting, yeast infection.
Anything more dangerous?
And anaphylaxis.
How about pseudomembranous colitis?
Oh yes.
All right, that's a life-threatening situation, right? You know that, right? If it's been ignored, it can actually lead to death, right? You know that. Okay, and patients, if not, can actually go and sometimes ends up on the operating table, correct? Now, having this in mind, right? And we have said this is the case, right? Do you always write something on your prescription? Do you always say, please discontinue should you develop GI upset or allergies? Do you think you should do?
I think you should, yes.
Well, wonderful, wonderful. I think this is the right way to do it. Just write it up on your prescription, correct?
Yes.
All righty, all righty. What is the best way to treat an abscess?
Treat the cause.
Excellent. And what else as well?
Incision and drain and whatever.
Excellent. So what did our great-grandfathers of medicine taught us long time ago? Whenever there is a pus, what do?
Drain it.
You evacuate it, right? So wherever there is pus, you evacuate. Okay? Do we all agree on this? Okay, Dr. Amin, beautiful presentation. Beautiful presentation. Thank you very much for standing up, doing this. I'm really very happy that you did it. I'm very happy that you have tackled a very, very important topic. And please, guys, ask Dr. Amin questions.
Thank you so much.
She really spent a lot of time. I know it's in 89 pages. It's not an easy article to read. It's very complicated. And she summarized it in a very nice way, by the way.
Thank you.
How about we run the poll and have Dr. Aman ask us questions? Dr. Pahal, there is a question. Maybe you can answer while people are answering.
No problem.
From Dr. Marwa. It's okay.
All right, question is, may you please just repeat what should be written in the prescription when prescribing antibiotics? So the location of where you are at, the clinic, date, the patient's name, address, and the prescription would be the antibiotic name. So for example, if you're prescribing amoxicillin and then the dosage, so for example, 500 milligrams for adults or 250 milligram per 5 ml for children, and then the how you would take the prescription. So for example, 1 tablet 3 times a day, for how many days you be prescribing it for, and dispensing how many tablets in total. Pharmacies, they always are a stickler about that. Even though if you write, take it 3 times a day for 7 days, even though they know how many that would be, you must write also the total quantity of the total tablets you're giving. You would give your name, your license number, and then signature. If it is narcotics, oh, sorry, that's just antibiotics, right? Yes, that's it. Oh, and yes, to discontinue if any adverse effects, like Dr. Hassan has says and Sally Green. Okay, sounds good. So the first question is, the results found that antibiotic use prevented which of the following in patients who had wisdom teeth extractions? Pain, fever, swelling, problems with restricted mouth opening. The answer is actually no evidence was found that antibiotics prevented the above. The second question is, the timing of antibiotic administration is most beneficial when? Pre-op, post-op, pre-op and post-op, or no clear evidence? And the answer is actually no clear evidence that the timing of antibiotic administration was important. The third question was that the vast majority, 21 of 23 of trials included in review included healthy patients undergoing impacted wisdom teeth extractions performed by oral surgeons. This is true. The fourth question was 5 of the studies evaluated tooth extractions in immunocompromised patients. The answer is false. Actually, none of the studies that were evaluated tooth extractions in immunocompromised. 5, none of the studies evaluated young children or older patients. This is true. Only healthy patients in their 20s were evaluated. Number 6, the possible increased risk of mild adverse effects of antibiotic use is, as Dr. Hassan said, at least 1 for every 30 patients treated. 7, when deciding whether to use antibiotic prophylaxis to prevent infective complications following tooth extractions in healthy patients, the practitioner should consider, this is E, they should consider the low rate of infectious complications, the lack of serious complications even in the absence of antibiotic prophylaxis, antibiotic resistance, and the possible increased risk of mild adverse effects. Number 8, immunocompromised patients need an individualized approach in consultation with their treating medical specialist. This is true. 9, the study found low certainty of evidence that prophylactic antibiotics may reduce the risk of infection and dry socket following third molar exos when compared to placebo. This is true. And number 10, the study found very low certainty of evidence of no increase in the risk of adverse effects. This is also true.
Thank you very much, Dr. Amin. It was very nicely done. I truly appreciate the effort that you have put. I know how hard it is to read that among your busy schedule, but thank you, extremely thank you for doing this.